Okay, so we've got the differentials for brain inflammation. So the patient is coming to you and they're presenting with fever and a headache. When they present with a fever and a headache, this is a sign of brain inflammation. Remember, anytime there is a fever, this is going to be obviously inflammation is occurring because that's sign. And if they also present with a headache, so now there's some kind of brain inflammation, and your differentials are meningitis here, abscess here, and encephalitis here. So the thing is, fever and a headache, the question will present to you with fever and a headache. Patient has fever and a headache. If they have photophobia and phonophobia, that's kind of like leading you towards meningitis. Now remember, in actual clinical practice, fever and a headache can be a sign of some kind of systemic dysfunction. However, in our clinical questions, we are going to encounter fever and a headache. If there's a stiff neck accompanying the fever and a headache, that could be a sign of meningitis. So fever headache plus stiff neck equals meningitis. Fever headache plus focal neurological deficit, this indicates an abscess. Why? Whenever there's a focal neurological deficit, this means that there is some kind of space occupying lesion. If there's a space occupying lesion, it could be an abscess, but what else could it be? It could be cancer. So before we make the diagnosis of an abscess, we need to rule out cancer. So we're going to rule out cancer. And then fever and a headache plus an altered mental status. Whenever there's an altered mental status, this is going to be encephalitis. So now remember, these rules are not hard and fast. These are just overviews to help you make the differentials for fever and a headache. Now let's go into meningitis. So meningitis is going to present with fever, headache plus stiff neck, and they're going to have a positive Koenig's and Brudzinski sign. So remember, Koenig, K for knee, B Brudzinski for the back of the head. So K for knee, Brudzinski, B for back of the head. Now, meningitis can be bacterial, and then we can start to look for specific bacteria. We can look for TB, we can look for Rocky Mountain spotted fever, we can look for Lyme disease, crypto, and viral. Now, in another video, I'll go into detail about how these would all present. Now, then we've also got abscess, okay? So, and then we've got encephalitis. Now, encephalitis can be West Nile. Remember West Nile, St. Louis, equine encephalitis. We have all these different types, but again, in clinical practice, when it comes to it, you're not going to go looking for these unless there is some kind of public health criteria that you need to meet. Now, how are we going to do the diagnostic workup for patients with fever and a headache? Okay, they present with fever and a headache. Firstly, you want to find out, is this patient safe for lumbar puncture? Is this patient safe for lumbar puncture? I don't know. Do they have any of the fails signs? Fails, F for focal neurological deficit, A for altered mental status, I for immunosuppressed, L for lesion, S for seizures. If the patient has any of these, that means that the patient is not safe for lumbar puncture. Remember, a focal neurological deficit tells you that there might be a mass occupying lesion. If the patient is immunosuppressed, they may not show the typical signs that another patient might show who's immunocompetent, the signs for increase in intracranial pressure, for example. So if the patient is an elderly or on chemotherapy, you need to then consider, is this patient immunosuppressed? Then would it be safe to do a lumbar LP? Now, if the lumbar puncture is safe, that's fine. Go ahead, go and do the LP. Now, if the LP is not safe, then what are you going to do? Obviously, you are going to order a CT scan first to check for what exactly is there. Is there raised intracranial pressure? And then is there a space occupying lesion? What is there? But are we going to do a CT scan straight away, or are we going to start antibiotics? No, you cannot do the CT scan straight away. You need to first order the antibiotics, give the antibiotics, and then give the CT scan. You must give the antibiotics before the CT scan. And what is the logic behind that? Why would we give antibiotics before the CT scan? Well, the reason is because basically, if you give the antibiotics and then they cause some kind of bad result in the LP, because obviously you're giving antibiotics, will the LP then be completely accurate for the culture and sensitivity? Maybe, maybe not. But it's okay. If we get a bad LP here, if you get a bad LP, but in a live patient because you've given the antibiotics, that is fine. But if we were to have a dead patient because you did not give the antibiotics but an accurate LP, then you would be in some deep waters, okay? Now, you check the CT scan. If the CT scan comes out negative, you can go straight to the LP. Now, within the LP itself, I know there's that table that you've learnt with the differentials between bacterial, viral, and TB or fungal. here you just need to look for PMNs. And if there are thousands and thousands of PMNs, that can tell you straight away that this is a bacterial meningitis. Now, if there aren't PMNs, if there's lack of PMNs, it can still be bacterial. It doesn't have to be, but it can still be bacterial if you don't have PMNs. But if you have thousands of polymorphonuclear leukocytes, that's what this is, polymorphonuclear leukocytes, then it's bacterial. You're going to give ceftriaxone, Vanco, and steroids. If the patient is immunosuppressed, you can then give ampicillin. And if there aren't PMNs, polymorphonuclear leukocytes, then it's likely not bacterial. So it can be crypto, it can be Rocky Mountain spotted fever, etc., etc. If you do an LP and you see lymphocytes, this points towards encephalitis. If you do an LP and you see lymphocytes, this points towards encephalitis. And when it comes to encephalitis, you want to be firstly treating, the only thing you do when the patient has encephalitis or you suspect encephalitis, the only thing you can do is treat HSV with acyclovir. Okay, now in the question, if they indicate anything to do with the temporal lobe, it's HSV encephalitis. If they indicate anything to do with a hemorrhagic tap, it's HSV encephalitis. In actual clinical practice, this does not absolutely guarantee encephalitis. This is not, the criterion only for encephalitis, but for HSV encephalitis. But in the question, you're being pointed towards HSV encephalitis if you encounter temporal lobe or hemorrhagic tap. Now, if the patient has encephalitis, giving them, you need to, if you suspect that, you need to diagnose with HSV PCR. If HSV PCR comes out positive, great, you can go back and you can continue treating with acyclovir. However, if it's negative HSV PCR, you can just give supportive care, and that is it. So I hope this was useful. I'm going to continue making some more neurology videos. Please like the video if it was useful and subscribe. Thank you.